Welcome to our video on post-term pregnancy and multiple gestations. Post-term pregnancy is when gestational age of the mother is greater than 42 weeks. Risk factors for post-term pregnancy include prior history of post-term pregnancy. Additionally, maternal risk factors such as nulliparity, obesity, and age greater than 35 contribute to the overall risk of post-term pregnancy. Moving on, let's talk about fetal and maternal complications of post-term pregnancy. Macrosomia is one of the most common fetal complications. Reason for this is that the longer the fetus stays in the uterus, the more it grows. Other than macrosomia, oligohydramnios can also occur in post-term pregnancy. In a post-term period, placenta becomes aged and calcified, resulting in placental insufficiency and therefore oligohydramnios. The worst complication of post-term pregnancy is fetal demise. Let's discuss maternal complications now. Mother might develop severe obstetric lacerations, either spontaneous or iatrogenic, due to fetal macrosomia during post-term pregnancy. Postpartum hemorrhage might also occur due to overdistension of the uterus by a macrosomic baby and the relative weakness of the myometrium. A 36-year-old G1P0 female comes to the physician at 42 weeks of gestation for a routine prenatal visit. Her pregnancy was uncomplicated. Ultrasound shows a large baby with increased biparietal diameter and femur length. The physician recommends inducing labor within the next several days. Which complication is this woman most likely to experience during vaginal delivery? This 36-year-old female presents at 42 weeks of gestation, which means that she has a post-term pregnancy. Ultrasound shows a large baby consistent with fetal macrosomia. Vaginal delivery of macrosomic fetus is commonly complicated by severe obstetric lacerations due to cephalopelvic disproportion. Another common intrapartum complication of delivery of macrosomic fetus is a postpartum hemorrhage. Let's finish this subsection by talking about the management of post-term pregnancy. Given all the complications that we explained on the previous slide, we should regularly monitor the fetus via non-stress test. We should also induce delivery prior to 43 weeks gestation. We will now start the last subsection of this lecture, multiple gestations. Dizygotic twins are also known as fraternal twins. Dizygotic twinning occurs when two separate eggs get simultaneously fertilized by two separate sperm cells. Therefore, dizygotic twins have different genotypes. Additionally, they always have separate chorions and amnions, so they always are dichorionic, diamniotic. Here we see an illustration of how dizygotic and monozygotic twinning occurs. Let's first concentrate on dizygotic twinning. Please take notice that there are two separate eggs and two separate sperm cells, which give rise to two separate embryos. Now let's talk about monozygotic twins. Monozygotic twins are also called identical twins because they have identical genotype and phenotype. Monozygotic twinning occurs when one egg gets fertilized by one sperm cell and then the zygote splits in early pregnancy. Chorionicity and amnionicity are determined by the time of zygote split. If zygote splits anywhere from 0 to 4 days, then twins have separate chorions and amnions. In other words, they are dichorionic, diamniotic twins. If, on the other hand, zygote splits from 4 to 8 days, then we receive monochorionic, diamniotic twins. If split occurs anywhere from day 8 to day 12, twins share both chorion and amnion and are appropriately called monochorionic, monoamniotic. Finally, if splits occur anywhere from day 13, we receive conjoined twins, meaning they share the body and several organs. We have used this illustration to discuss dizygotic twinning, but now we will concentrate on monozygotic twinning on the left of this image. Pay attention to the fact that there is only one egg, one sperm cell, and one zygote, which then divides into two several days after fertilization. Let's move on to the twin-twin transfusion syndrome, also known as TTTS. TTTS is caused by abnormal arteriovenous anastomosis between umbilical arteries of one twin and the umbilical vein of another twin in monochorionic pregnancy. Blood flows from the umbilical arteries of the donor twin to the umbilical vein of the recipient twin. Donor twin develops hypovolemia because most of the blood goes to the recipient twin. Additionally, donor twin has anemia due to lack of red blood cells and oligohydramnios due to decreased glomerular filtration rate. In contrast, recipient twin exhibits hypervolemia and polycythemia because he receives extra fluid with lots of red blood cells. Recipient twin also has polyhydramnios due to increased GFR. Management of TTTS is serial ultrasound, amnio reduction for polyhydramnios, and laser ablation of anastomosis. Here we see an illustration showing twin-twin transfusion syndrome. Please pay attention that the donor twin is smaller and more fragile with oligohydramnios, while recipient twin is bigger and plethoric due to polycythemia with accompanying polyhydramnios. We'll now discuss the timing of delivery of twins. Time of delivery depends on the chorionicity and amnionicity. Dichorionic diamniotic twins are usually delivered on 38th week of gestation. In contrast, monochorionic diamniotic twins are delivered on 36th week of gestation. Finally, monochorionic monoamniotic twins are delivered on 32nd to 34th week of gestation due to high risk of stillbirth. Let's move on to the route of delivery in diamniotic twins. Route of delivery during twin pregnancies is a separate topic itself because the sequence of delivery depends on the presentation of twin A and twin B. If we have cephalic twins, that is, both are in cephalic presentation, we perform vaginal delivery of both twins. If we have non-cephalic twins, we perform cesarean delivery of both twins. Cesarean delivery of both twins is also performed if we have non-cephalic twins. Finally, in case of cephalic non-cephalic twins, we vaginally deliver a twin A and perform the breech extraction of twin B. Finally, let's talk about timing and the route of triplet delivery. Monoamniotic or diamniotic triplets are delivered during 32nd week of gestation. In contrast, triamniotic triplets are delivered during 35th week of gestation. As for the route of delivery, a preferred route in triplet gestation is almost always a cesarean delivery. A 25-year-old G2P1 female is admitted to the labor and delivery suite at 38 weeks of gestation for planned labor. Both of her pregnancies were uncomplicated. She has a past medical history of gestational diabetes mellitus in her current pregnancy. Her vital signs include a temperature of 37 degrees Celsius, blood pressure of 115/75, heart rate of 95, and respiratory rate of 17. Ultrasound reveals dichorionic diamniotic non-cephalic twins and an amniotic fluid index of 22 centimeters. Which of the following is the best route of delivery for this patient? A. Cesarean delivery of twin A and vaginal delivery of twin B. B. Vaginal delivery of both twins. C. Cesarean delivery of both twins. Or D. Vaginal delivery for twin A and breech extraction for twin B. This patient has a twin pregnancy. She has dichorionic diamniotic non-cephalic twins. This means that the twin A, that is the one who is supposed to be delivered first, is in any presentation other than cephalic, while twin B, the one who is supposed to be delivered second, is in cephalic presentation. Whenever the twin A in diamniotic pregnancy is in non-cephalic presentation, we cannot perform vaginal delivery because there is a high risk of asphyxia for twin A. Instead, we should perform cesarean delivery of both twins, even for twin B who is in cephalic presentation. Therefore, correct answer is option C, cesarean delivery of both twins. This is a slide that we already discussed, reminding us the route of delivery for diamniotic twins in different presentations. Again, as we can see, non-cephalic diamniotic twins are both delivered via cesarean section. Now let's discuss why other options are incorrect. Option A, cesarean delivery of twin A and vaginal delivery of twin B, is incorrect because once cesarean section is done for the first twin, we can easily deliver the second twin via cesarean section as well. In other words, we do not have to deliver twin B via vaginal delivery once abdominal incision is made for cesarean section. Option B, vaginal delivery for both twins, is incorrect because vaginal delivery of non-cephalic twin A is associated with increased risk of obstetric complications like perinatal asphyxia. Finally, option D, vaginal delivery of twin A and breech extraction for twin B, is performed when twin A is in cephalic presentation while twin B is in non-cephalic presentation. In this case, twin A has non-cephalic while twin B has cephalic presentation. And that concludes our lecture on fetal complications of pregnancy.